Now we're going to take a deeper dive with 4 subject matter experts to talk about the future of telehealth. For that, I'd like to welcome Dr. David Cockrell, owner of Cockrell Eye Care Center, Samantha Zenley, Senior Regulatory Policy Specialist, National Council on Aging, Susan Poland, Public Affairs and Advocacy Associate Executive Director for the American Public Health Association, and Natasha Sukolyevich, Executive Director of Telehealth at the University of Pittsburgh Medical Center. Joining them is the Hill's healthcare reporter, Peter Sullivan. Peter?
Thanks, and thanks again to everybody who joined us. Now we've heard from our lawmakers. We're going to dive a little more in with our panel to talk a little more. So, Natasha, I thought maybe I'd start with you. I mean, obviously working at UPMC, have used telehealth. Maybe you can just talk about, just start us off with kind of the benefits you've been seeing, how you guys have been using it on the ground there, and how that's been working for you.
Sure, Peter, thank you, and happy to share our story. So we've been engaged in telehealth since late 2006, early 2007. Started out with what we heard this morning, the use of technology to be able to access patients that come to community hospitals, to the ED, and that have a neurologic event that is presumed to be a stroke event. And through the leadership of our chair of neurology, Dr. Larry Wexler, he saw the vision to be able to deploy his team that wouldn't be able to come in person to these community hospitals, and instead to access his expertise and his team's expertise remotely through the use of technology. We now have over 30 locations, more non-UPMC owned hospitals than owned hospitals throughout various communities across Pennsylvania that we provide telestroke services to. So as you can think about, so that was a game changer for those patients that didn't have to be transported past their local community hospital. And then the key too is that they can remain in that hospital, so they're closer to their families, they're closer to what they're familiar with. So that was our first segue in. And then behavioral health, which is something that was mentioned earlier today too. Huge need across the country, so we were able to use telehealth to reach many more patients across the state that needed behavioral health services. From there, we evolved and we started looking at how can we also expand access in areas where there may be subspecialists that aren't available, where patients are remote enough that the drive time is a heavy burden. And we developed what we branded as our UPMC teleconsult centers, which are basically virtual multi-specialty clinics in these communities. And through those types of access points, we've now been able to see over 7,000 patients. We have over 32 subspecialties that are delivered remotely. And cumulatively, the impact just on transportation alone has been close to $900,000 in cost savings. So as you can think about, that evolution, what the impact means to access to efficiencies, we're a large system that continues to grow, and so it allows us to leverage our subspecialists more efficiently, and it allows these patients who we evaluate in terms of their satisfaction and ask them, what would you have done if this wasn't available? Well, interestingly enough, about 30% say that they would have foregone care altogether. So it's a game changer in terms of continuity of care and being able to manage patients with chronic conditions and oftentimes multiple chronic conditions, looking at what the outcomes are clinically and minimizing those acute events that can be avoided. We now also have a direct-to-consumer app that's on your smartphone, tablet, UPMC Anywhere Care, that's available to anybody across the state of Pennsylvania, that gives them basically access to a provider in their pocket. So it's bringing that doctor back into the patient's home where and when they need care or need to communicate with a provider. And we continue to grow with remote monitoring. So all these various use cases that you often hear in the telehealth space, we've had the opportunity to both test, expand, and integrate into our care continuum. So with that, I'll turn it over to one of our
great.
colleagues.
Thanks for that. Yeah, I guess I'd maybe go to Dr. Cockrell as well. You're also someone who's practicing using this. I mean, how have you been using it, and what kind of benefits have you seen from telehealth?
You know, I've had the opportunity to participate in telehealth in Oklahoma for about 10 years, and from a variety of different avenues. It initially started with diabetic care. We have a large Native American population in the surrounding area. We provide care for multiple Native American reservations. And so because of the significant number of diabetic patients there, that's where telehealth started. Telehealth has its promise and it has its challenges. And the promise is immediate care, as Natasha talked about, and immediate consultation. You know, I think the thing that we've got to keep foremost, and what we've certainly seen in the populations I've worked with, is having the doctor-patient relationship first. Telehealth doesn't take the place of that. When it comes to long-term systemic care, as we manage diabetic retinopathy, for instance, it's having a physician-doctor-patient relationship where somebody's intervened, where it's not just someone looking at a scan. And so it's got the promise of delivering that, which we've seen it deliver. We've seen a decrease in the rates of non-proliferative diabetic retinopathy transition into proliferative diabetic retinopathy over time, as we've been able to bring a specialist in at an earlier point in time. The challenges are that there's many different telehealth platforms that we all have to decide. Is it going to be live interactive? Is the physician or the nurse practitioner or the PA going to be talking to that patient one-on-one in a live time? As the senator said this morning, looking at the rash on their arm, right? That's live. Is it going to be some type of stored forward information where the scan's taken and saved and then is sent forward to some physician or some other practitioner to look at and then comment back? That's more of a consultation problem. And then also then just remote monitoring. And so all those come into play and they all work quite well. The challenges I've seen is, the biggest challenge I've seen is that the doctor-patient relationship. The second one is just the credentialing privileges. As we've seen some of the nascent programs rolling out in Oklahoma, and we're far behind where she's talking about, is a credentialing aspect and the privileging aspect that has to take place for that doctor, me, having the credentialing privileging to provide that care. I was asked to participate in a panel to look at some of the care for reservation in Mexico. Well, I'm not licensed in Mexico, so I've got to be licensed in that area. If I'm actually going to be if I'm a consultant, that's one thing. Maybe my licensing and privileging is different. But if I'm a going to directly intervene, then I've got to be licensed in that state, because there's the downstream situation of who's got responsibility and liability, right? Yeah. So we've got some of those challenges to work out from a physician standpoint, but I think it's very promising. From an eye care standpoint specifically, I've seen it work well. I've seen it work poorly. And you know, I've got a young man that's going to see a neurosurgeon today that's 3 years old that started out as a telehealth patient that I insisted on seeing in my office as opposed to that. As it turns out, he's got some particular type of brain tumor that started out truly as a telehealth patient. So that's the downfall if you don't have that physician involved, that maybe care is delayed longer than it should be.
Right, yeah, that's it.
Should have gone that way.
Yeah.
That's a great ending.
Yeah. So right, we've talked about, you know, there's some you could even start off in telehealth and then kind of it can evolve. But I mean, there's some instances where you kind of need to be there. So maybe Susan, to talk about some of what do you view as kind of the limits of it sometimes? I mean, are there cases where you just really need to see someone in person, and what are the cases where maybe it does work better to have telehealth?
I'll start with the places where it does work, because our focus really is on prevention and moving upstream. And so there's lots of opportunities in all of these different programs where interaction with a patient can minimize their need to go to a doctor's office. And for people who have limited abilities to travel, who have limited transportation, it's a great opportunity to expand access, and that's really important. But you can't give a flu shot through a telehealth process, and you can't necessarily create communities that are walkable and that offer opportunities for health. And so there's really huge steps forward that we can make in terms of clinical care, but in terms of keeping people out of care and keeping people healthy, there are obvious limits. Yeah. And what it can also do, though, for people who have chronic illness, is it can minimize secondary impact, and that's an important component as well.
And at the National Council on Aging, I think you bring up a good point about minimizing secondary impact. Telehealth has a huge promise, as the word that we keep using, in chronic disease self-management. And so like you said, there's diabetes self-management programs that you can do online. I think that all these things that we're seeing as challenges in terms of how do you deal with licensing issues, or how do you deal with different types of technology, these are issues that people are working on right now, and there's an evidence base for diabetes and these diabetes programs, and organizations like ADA and the American Association of Diabetes Educators, they are committed to these programs, and they have licensing standards set out for these programs. So I think, sometimes it's a case-by-case situation, but there's a lot of smart minds working on these issues. To me, the real issue actually in telehealth is the access problem in terms of the disparity you see, and this conversation was brought up earlier in terms of broadband, and that the folks who really need it out there are the folks who don't have it.
Mm-hmm. And I mean, how have we seen, I guess from the patient's perspective, especially if you're an older person, I mean, do we find that the patients are usually, accepting of this or into this, or are some people saying, no, I don't want to see my doctor through technology?
I'll comment on that for a minute.
Yeah.
We've got obviously a rural patient base, we've got an elderly patient base as well, and so we see some of our older patients that don't have the technology at home to be able to do it from a home-based situation. If they can go into one of our local communities and avail themselves of technology, we can have that interaction face-to-face. Broadband is a huge issue in rural America, as the representatives talked about earlier. Mm-hmm. The technology is just not there. And then trying to get the technology platforms to talk to each other is also a challenge. Mm-hmm. There's so many different platforms out there. So what I find is our older patients, we participated in a small research study on diabetic care a couple of years ago, and our senior patients were the ones who truly had trouble actually just getting online and filling out the information, just simple filling out the information to give us back for the research itself. So it's a challenge from technology, it's a challenge from integration based upon comfort with the technology.
So the good news is that there have been a number of vendors, especially in that remote monitoring space, that allow you to have a very simple tool, a tablet that is then deployed. So you give that patient the tablet, you set them up, you make sure that they know how to answer the questions. The questions can be as simple as click on the smiley face, the frowny face, how are you feeling today? So there's ways, I think, to integrate and make sure that it's simple enough for anybody to use. And so I think that these are challenges that are being overcome and in some cases have already been overcome. And we don't see a lot of resistance, I think, based on age. Most of us today, regardless of age, have some sort of cellular phone that we carry with us. Mm-hmm. So even if you can deploy the phone, if they don't have a desktop computer, that's an opportunity to embrace, and I think that there's technology that's available that can be then leveraged, and so much of the growth, technology has always been ahead of where we are in terms of operational adoption. We still see barriers with reimbursement. We see in Pennsylvania, we have a Senate bill right now that's in front of the legislative committee to vote on that would allow us to be able to be reimbursed by the commercial payers, and we're behind. So there's over 36 states across the country that have what are called parity laws, not necessarily equal parity, but it doesn't allow the commercial payers to blanketly deny coverage for a visit if it's done in person when it's done via telehealth. But Pennsylvania still doesn't have that. So that's been an issue for us. And then the other issue is the CMS definitions of rural health provider shortage areas don't always make intuitive sense. So we have areas that are over an hour and 45 minutes away from an urban location that have shortages of primary care, shortages of subspecialists. They're not designated as rural health provider shortage areas, which means Medicare, if you have Medicare, you don't have reimbursement for telehealth. So I think there's still opportunities for us to catch up. And once telehealth becomes mainstream medicine, then I think we'll start to see the adoption and the flow to really maximize the opportunities that are available.
There's another opportunity that I think we have if we train our providers correctly, which is to allow them to look at not just the specific issues that they're discussing the patient with, but to try and understand what's going on in that environment. So if you are doing an interaction with somebody in their home, you can look around. If there's an issue with mold, if there's an issue with cleanliness, it can help you understand something you might not be able to see if you're not able to actually get into the home this way. So there is the possibility to create that old style home visit if it's done well and if the providers are trained to look beyond just the specific questions that might be on their sheet to look at the disease that they're focusing on.
Excellent.
I guess I'd add to those comments. I agree with both of them. I think, technology, innovation leads technology, right? And then the adaptation of that technology is always a little bit behind as we try to figure out how to utilize it, how to get our patient base to utilize it, how to get the providers to utilize it well, and to be all-encompassing. I think, again, that's the promise of it as we continue to roll out and we see it in more areas. Eye care works very well for when it's done appropriately and the technology matches. So I think it's an exciting time for us if we can get, from the regulatory standpoint, to come together with it, along with the licensing, along with the fee parity, along with the payment schemes that are coming online, and as we work with CMS right now, trying to help them adapt what they're going to with the function of how they incorporate telehealth.
I mean, I guess since we're in DC, I mean, if you had one thing that you'd want either Congress or CMS, to change, I guess what would any of you say? I mean, is it the payment issues? Is it broadband access? I mean, what's kind of the one thing that you'd really like policymakers to do on this?
So I'd like to commend CMS for, in 2019, removing that rural health provider shortage area restriction for telestroke. That's the first clinical area that is now going to allow patients, regardless of community, where they are, to be able to be reimbursed. So the adoption then and the barriers to these smaller community hospitals that are cash-strapped to begin with to be able to leverage, there's going to be much more incentive for them to be able to utilize telehealth. But that's one clinical area. So if we can start to leverage and look at other clinical areas to do the same thing and not have arbitrary limitations to the opportunity to integrate, I would say that would be a big resource. I was invited to a meeting in DC where the group was talking about the expansion and incentives with broadband connectivity, but then there was a question, so there's the broadband connectivity that's expanded, but why isn't telehealth being used? And I think people just think that if you have broadband, you can click the switch and somehow people are going to start using it to deliver care. I think there's an opportunity for us to adopt a model that can actually be implemented, start looking at where we do have broadband, how can we now leverage that and what's needed. So hopefully that committee will continue to work on those details too.
Yeah, I don't think you can actually forget either of those issues. I mean, we can't, in DC, we like to come up with 10 issues at once. Right. But I think that, payment and access, building off what you said, I think are tied together. So like you said, it's one program that they've removed the rural restrictions. And as Congresswoman Matsui said, you don't just see access problems in rural areas, you see access problems in urban areas. People still have to go to community centers. You see grandparents who are taking care of their grandchildren and they don't have the time component that's necessary with access to run to the doctor or go to a center to take a self-management class. There's a lot of different ways to define access, and so if CMS or Congress looks at this issue more closely, hopefully they can come up with a more comprehensive way to address that component of payment so these programs can be expanded.
Yeah, my comment would be, I think there's one thing I'd ask for as CMS looks at this is to make sure that the doctor-physician relationship is sacrosanct and that it's always part of all telehealth. Certainly it's not going to be every bit of it, but I think as long as that patient has a direct relationship with a provider that's important, you don't want to dissociate or detach from that. That's the number one thing to ask.
All right, I think we're ready for some audience questions. If anyone has a question, please raise your hand and then wait for a mic to come to you. So I see right here. And please introduce yourself first.
Hi, I'm Ellen Milheiser. I write the newsletter Synopsis on healthcare. The comment was made that provider licensing remains a problem for telehealth. I've heard the policy suggested that instead of licensing where the patient is located, that the government require the license be held by the physician, and as long as the physician is licensed in any state, he or she could provide care to a patient in any other state. DOD and VA already do this. It's, what would you think?
I'll give you the challenge to that. I also sit on a regulatory board in Oklahoma. And so in a situation where you're licensed in one state, rendering care in another state, and something goes wrong, who has responsibility and what agency is going to deal with that? And so if a provider in Oklahoma is rendering care in New Mexico, and for some reason something goes wrong and some type of litigation takes place, or some complaint to a regulatory body, if that patient in New Mexico is complaining to a regulatory body in Oklahoma, they're going to have a variety of problems to get anything done. So at this point in time, the TJC, the Joint Commission, has established a set of standards indicating that the person doing live access needs to be licensed in the state where the patient is, so the patient has a direct route to resolve a problem. That's the biggest challenge I see right there. It's the responsibility, and at the end of the day, for that patient.
Any other questions?
Hi, my name is Seema Kazmi. I'm a pharmacist, and currently I'm serving as the communications chair for the Maryland Pharmacists Association. And my question is regarding, with some of the in-home visits and telehealth monitoring, some companies have a technician go out to the patient's home, and then the provider communicates with the technician and the patient for chronic care management services. And just wanted to know if you have any comments on that type of model.
So, can you just clarify for me? I'm sorry, I know the mic was taken away.
So some providers, let's say the provider is remote, and then a technician who is local to the patient, they'll be with the patient in their home. One of the providers had mentioned that some of the older individuals have difficulty accessing the internet and using technology. So some of these technicians, they visit the patient's home, and they'll have an iPad with them, and they'll basically facilitate that telehealth visit with the provider. So wanted some commentary on if you...
Yeah, so we haven't done technicians, but utilizing home health nurses or some of these clinical facilitators that actually do come to the patient's home, and then being able to do, whether it's a wound nurse or, again, a home health nurse when patient's discharged, to be able to follow up with them and bring that tablet. So we have done those types of things, and then they can be tied into another clinician, whether it's a nurse practitioner, a physician's assistant, or actually a physician, depending on what they're trying to accomplish, in terms of the touch base, the acuity of what they're reviewing. But I haven't heard of technicians, so I think that would be interesting. It just depends, what is that person who's at the, what we say bedside, but in the home, what are they actually tasked to do? If they're not doing anything clinically, then it probably could be a technician.
So when I was referring to technicians, so I'm a pharmacist, and I'm aware of, with medication therapy management services and chronic care management services that pharmacists provide, perhaps a medical technician or a pharmacy technician. They also call them like pharmacy assistants. They'll come out to the patient's homes and help facilitate that pharmacist consult. So if that's...
I've heard of it. We don't do it, but it makes a lot of sense to me because med reconciliation is a huge issue, I think, for everyone. So I believe that there are programs, and there's probably some reports that have already been published, but I'm not as familiar with them because that's just not one of the areas that we've recently focused on. So
I think it's a good idea. I think anything we can do to pass that health information along to the end-stage provider, whoever that is, and if you've got a technician there who may be also able to ascertain, as one of the other panelists talked about, the state of the patient itself, because so much of healthcare is watching that patient, seeing what they're doing, and if it's truly electronic, the provider can't see that. So if there's a technician there who can also comment on something that that patient might not say, that's going to help deliver the care. So I think it's a good idea.
There's a program in a New Orleans-based health system in which a lot of what they're doing is remote monitoring. So they're using remote blood pressure monitor, remote scales to diabetes measurements, And I think that especially early on in that process, having a technician help the patient walk through and understand how all these pieces work together would be a critical piece to make sure that in any future conversation with a provider that's remote, the technology is working well to maximize the actual interaction.
One more quick question. In the back.
Hi, my name is Kim. I'm a student nurse at Georgetown. And so one of the things we've been talking about in school is, physician and provider burnout. And so we've been talking a lot about increasing access. How do you prevent, think that you could see that prevention of provider burnout, especially as we have physicians and nurses leaving the field?
So that's a great question, and I'm glad you mentioned it because, I think what we've adopted now is no longer the triple aim, it's the quadruple aim, and the quadruple, the fourth part is the provider part. So helping to not just improve the patient experience, but the provider experience. And to do that, we need to minimize the disruption to the usual provider workflow. A big piece of that has been integrating telehealth within those electronic health record systems. So for providers already in a system that they've been mandated to use on a daily basis, how can you integrate the workflow of that telehealth visit to be seamless within that in-person workflow? And so we've focused on that over the years since the beginning. A lot of the telehealth vendors separated themselves from EHRs, and rightfully so, because that was so complicated and there was no incentive for any kind of interoperability. I think the EHR vendors too have recognized that. So you have the large players that are either integrating those capabilities, have them already, and now starting to leverage them, or working with vendors to integrate that opportunity to be able to have telehealth visits pop up on a provider schedule and having you be able to click on that link then and directly connect with that patient who's connected on their end. So I think that's a big piece of it.
I think you asked an essential question. Remember I said there are promises and challenges? I mean, the workload's immense, and if you take that on, it's going to have to fit into the schedule. It can't be an on-demand while you're in the middle of your patient day. It's going to call for increased number of physicians, increased number of care providers to actually be able to manage it.
All right, I think that's all the time we have for this panel, unfortunately. So thank you, and thanks to our panelists.
Thanks, Peter.